self-identify. Term has been used and embraced by the community as inclusive of marginalized sexual orientations and/or gender identities. Use person-centered, gender-neutral, and preferred terms for patients, as well as using preferred terms for patient anatomy. Respect how people self-identify, and with their permission, use this language, including preferred pronouns. Although applicable to all patients, with LGBTQIA+ patients, there may be either discomfort or even unwillingness by healthcare providers to discuss sexual history. Often, there is a notion that sexual history for LGBTQ+ persons should somehow differ from that of cisgender and/or heterosexual persons. Using an organ-based screening approach rather than a normal review of systems is recommended by the American Society for Colposcopy and Cervical Pathology. The CDC recommends considering for everyone the 5 Ps to guide the essential aspects of a sexual history: partners, practices, protection from STIs, past reproductive and sexual history, and pregnancy intention. The best predictor of cervical cancer screening uptake is a healthcare provider recommendation and the healthcare provider-patient relationship. Positive experiences with healthcare providers and within healthcare settings are key to LGBTQIA+ patients' cervical cancer screening adherence. Healthcare providers must first avoid assumptions, then move beyond neutrality, which reinforces heteronormativity and gender normativity. Patients must have opportunities to disclose sexual orientation and gender identity, and the healthcare environment must be welcoming and safe. The onus is on healthcare providers to be willing to examine their own biases, including the likelihood that implicit biases affect the care that they provide. The National LGBTQ+ Health Education Center has provided 10 strategies for creating inclusive healthcare environments for LGBTQIA+ people. These include that leadership is actively engaged, organizational policies that protect LGBTQIA+ people, non-discrimination policies, restroom policies, family and support person policies, for example, a physical and virtual environment welcoming of LGBTQIA+ people, forms reflecting LGBTQIA+ people and their relationships, and partnerships created within the LGBTQIA+ communities. All staff should receive training on affirming communication and care. Sexual orientation and gender identity data should be collected and used to improve healthcare outcomes. All patients should receive routine and inclusive sexual health histories. Clinical care and services should meet LGBTQ+ individuals' healthcare needs, and LGBTQ+ individuals should be recruited and retained. Healthcare system and organization changes, both big and small, can help to overcome barriers faced by LGBTQIA+ people that keep them from accessing high-quality care and preventive care like cervical cancer screening. And now I will turn it back to Dr. Colombo.
Thank you. Thank you so much for this very, very nice presentation. Now, in fact, there are wonderful opportunities for screening, but despite that, unfortunately, still too many patients are diagnosed with cervical cancer. So now I want to ask Dr. Monk, what can we do now for patients with locally advanced cervical cancer? I know that there are very good news, so please tell us.
Nicoletta, that's great. I'm so excited to be here with you. This is a very important program. That was a powerful message, and I'm really, really grateful to be included. I think it's clear what the enemy is here. And I know that this is dramatic, but I want it to be dramatic. And that on the left, my residents call that a cauliflower lesion, and I don't want you to think about cervical cancer every time you eat cauliflower, but this is what we're talking about. And on the right, this is locally advanced cervical cancer, too large to be resected and appropriate for chemotherapy and radiation. And this differs around the world. And you can see, for example, in Kazakhstan, it's 68%, in Germany, it's 26%. It matters where patients live as to what the global incidence is of locally advanced cervical cancer. And again, this is what I want to talk about, because when caught early, and thank you so much, Dr. Aleshire, for that nice presentation, cervical cancer is curable. But when it's locally advanced, it really presents a clinical challenge. So I know you know how to take care of patients. It's actually a two-handed pelvic exam because you can examine the paracervical soft tissue based differently from your dexterity. There's multiple imaging, pelvic MRI, PET scan. We put contrast in the vagina routinely. It's very nice. You should try it. Surgical staging is unproven and rarely used. I can't remember the last time I examined a patient under anesthesia unless I was having trouble getting a biopsy. So generally, there's little value there. Since 1999, this has been the global standard. It was a clinical alert, weekly cisplatin, added to external beam and intracavitary radiation, GOG 120, published in the New England Journal, NCCN recommended, and that's where we are. The technology for radiation has evolved. We now use intensity modulated radiation, all on the right. The problem is that where cervical cancer is the most common, radiation is the least common. There's a mismatch between the radiotherapy resources worldwide. Again, we can't fix that, but I want to draw attention to that. The longer the treatment lasts, just simply stated, the cancer starts to grow back. So there has to be timing. We try to do it within 8 weeks. You can even do it within 7 weeks. And generally the brachytherapy actually starts during the external beam radiation. Brachytherapy is essential. It improves local control and increases survival. And this is a very nice paper. It's more than a decade old. The problem is that the number of brachytherapy units is decreasing for many of the socioeconomic challenges that were just pointed out. We underutilize brachytherapy. We need to make sure that brachytherapy is part of the treatment paradigm, weekly cisplatin, external beam, and brachytherapy. And we've already heard it, there are racial disparities for brachytherapy. Again, we need to defeat that. And this shows that in the Black American population, they do not receive the same treatment that the non-Black population does. And just like external beam disassociation, again, where radiation is needed the most, both external beam and brachytherapy, it exists the least. So I think one of the key things we're going to talk about here, and I'm so excited, is immunotherapy. I think if you're not familiar with immunotherapy and solid tumor oncology, you probably, I'm not sure what your excuse would be, but I'm very excited to present to you this study, and it's an NGOT collaboration. Thank you, Professor Colombo, for your leadership in NGOT CX11. It's a collaboration, GOG 3047. I'm going to call it A18. It's a randomized phase 3 trial adding pembrolizumab to the chemotherapy and radiation that I just described, and then continuing pembrolizumab in the maintenance phase every 6 weeks for 15 cycles. Very, very difficult trial to do. We did it during COVID. It was a very exciting study for us. It took a long time. We were very intentional. We were on time, and we performed a high quality study. The patients were balanced based on common demographics and tumor related factors. And again, very proud of this result. So it's interesting that we thought that PD-L1 expression was relatively uncommon. It's not. Most patients have it. These were at high risk locally advanced cervical cancer. There are two groups, this 1B2, 2B. This is the 2014 staging. So lymph nodes were not incorporated in the staging. And about half and half. So 1B2, 2B, 3 and 4A. And I'm here to tell you that the FDA approval was in the higher risk 3 to 4A, and I'm going to get into that. Almost all patients had nodal involvement, and I think that's important to note. Pembrolizumab did not overcome bad radiation. The vast majority of these patients got modern day radiation, as evidenced by IMRT and dose. Now, this study was so fantastic in its outcome at the first interim analysis, what we call IA1. It had a hazard ratio for progression of 0.70, published in Lancet Oncology as a collaboration between NGOT and the GOG. Our good friend, Kendall LaRusso, was the first author. This is now from that high-risk population. This is actually from the U.S. prescribing information. This is the 596 higher risk stage 3 and 4A. You can download these slides and look at these, so I'm not going to belabor the point. But this is the impact that you got. This is what led to FDA approval, okay? And I'm happy that you have this for you and your patients today, FDA approved since January. Now, the progression-free survival was updated at ESMO. We just got back from Barcelona. It got a little better. The updated progression-free survival is now 0.68, got a little better. And you can see, if you look at the left is the PFS from the IA1 to the IA2. You can see, let's say in the 1B2 to 2B, it got a little better, it was 0.91, now it's 0.81. With maturity, data generally gets better, it doesn't get worse. That's how these interim analyses are constructed. So I want to compare those groups to you. The overall survival was updated and it got better. The overall survival now in IA1 was 0.73, but now it's 0.67. It got better. And it'll be very interesting to see if the indication statement, which only includes stage 3 and 4, is updated to become the 1B2 and 3B. So to 1B2 and 2B. But today, the indication statement is, as I say, because it's the 2014 staging, it is sidewall involvement, hydronephrosis, or bladder or rectal extension. And here's the subgroup analysis. You still see that the hazard ratio for overall survival in the high-risk group is 0.57, and in the lower group 0.89. Now, I led another trial with a very similar trial with a PD-L1, durvalumab. It's on the left. I like this trial. I was the first author of, but it was negative. How can CALA be negative and Keynote 18 be positive? I'm not sure, but one was a PD-L1 durvalumab and pembrolizumab was a PD-1, and I think that's important. Now, I want to end a little bit on Interlace. Interlace now was presented a year ago, still not published. Interesting, right? This was neoadjuvant chemotherapy, and neoadjuvant chemotherapy done through an investigator-initiated trial has questions. The radiation was not as modern, but the progression-free survival and the overall survival is provocative. But because it's not published, we still have many unanswered questions, and that is not utilized in my practice. I utilize the FDA-approved pembrolizumab. I follow the label, which is the sidewall involvement, hydronephrosis, bladder and rectal involvement. So I don't know if we'll ever sort some of these things out. Surgical staging, as you know, hypofractionation is a thing in breast cancer. I don't know when to do and start brachytherapy. I talked about the timing, but it's sort of an individualized situation, because if the tumor is too big, the brachytherapy doesn't cover the tumor. But if you wait, when the tumor is smaller, you prolong the length. Interstitial radiation is something that I'm a big champion of. I don't know if they'll ever sort that out. I don't know why Cal failed and 18 succeeded. They were very similar. If you look at BEAT-CC, which included bevacizumab, we're going to hear about it, and recurrent cancer with the Tezo PD-L1 versus 826. Again, maybe you can figure that out. I think that we need to assess cure. We sort of teach people that you need to do a PET CT 3 months after, probably really 6 months, because tumors can still be shrinking in 3 months. Again, these are things I don't think we're ever gonna figure out. It's time to move on, though. A18 was great. We now have bispecific antibodies. This is a bispecific for PD-1 CTLA-4. This is a maintenance strategy. The antibody is not given during the radiation. It's called volrustomig, and this study is being done around the world. I apologize for not having the NGOT number there, but I encourage you to enroll on this study, which is open. So that's exciting. Professor Colombo, I want to ask you, is the standard that I described for locally advanced cervical cancer the same in Europe? Is this a global standard, or is this just a US standard? And do you have A18 approved yet in Europe?
No, no, we don't. We don't have A18 approved yet. But we do have, of course, pembrolizumab approved for recurrent and metastatic cervical cancer. Just to let you know that the interlaced paper will come out on the 14th of October in the Lancet. So we will have the published results. And then, of course, we are waiting in Europe for the approval also of A18 and to become available for all our patients, because I think it's an incredible advantage and advance in the treatment of locally advanced cervical cancer for sure. Yeah, that's a situation in Europe. So hopefully.
That's interesting.
Yeah.
I can't wait to read Interlace. And is that utilized, or I'm sure it is. What's how much in how will you decide between Interlace and A18 when it gets approved?
Well, I don't see really the competition. I think these were completely different population, as you pointed out. Interlace, we had more, locally advanced, but still early stages, I would say. Very fewer with positive lymph nodes, while in A18, all patients had positive nodes. So it's really a different population. So I think both approaches very interesting, but of course, probably in my mind, the best will be to combine both of them. I mean, the induction, I think induction treatment, whatever it is, chemo or even pembro, and then followed by chemoradiation and then maintenance, probably it could be the best option right now. But of course, we need to do randomized study for that. But the excitement is that we have new opportunities and new possibilities for these patients with locally advanced cervical cancer. So I think for patients is very good news. I mean, we have the induction, we have the IO together with chemoradiation and maintenance. So at the end of the day, what it is important is to improve the outcome of our patients. So I think we have 2 positive trials, and that's very good for our patients. Yeah.
I am really excited to hear your talk, and I just want to thank you before you show us data that you're very passionate about. You've been a world leader here. And I utilize the things that you've taught me individually, but also through your clinical trials every day in the clinic. So excited to hear you.
Okay, thank you so much. So we are now moving to the treatment of recurrent and metastatic cervical cancer, because unfortunately, this is still a problem, particularly worldwide. And here you see the progress in the treatment of first-line metastatic and recurrent cervical cancer over many, many years. You can see when I started practicing, we were using mainly cisplatin alone. Then we started with a combination, so we improve a little bit the outcome of our patient. Then we established that the best combination probably was cisplatin and paclitaxel. And then the big improvement was given by the advent of bevacizumab, as you know, and bevacizumab improved overall survival for patients with with cervical cancer. But unfortunately, this happened over, as you see, from 1983 till 2013. So it took so many years to get an improvement in the treatment of metastatic and recurrent cervical cancer. But now we understood since few years that immunotherapy could be a good way to go for cervical cancer. There is a strong rationale for using IO in cervical cancer. As you know, HPV infection is the cause of more than 90% of cervical cancer. And HPV positive tumor microenvironment is enriched for PD-1 positive T cells. So in fact, now we have these wonderful drugs that can act in this situation. So it was really rational to test anti-PD-1 and anti-PD-L1 in cervical cancer. And that's what we did. And we started with single agent, anti-PD-1 and anti-PD-L1, particularly in second line, so not in the first line treatment. And we saw activity. The overall response rate was around 14% or 16%, a little bit higher for PD-L1 positive tumor. But of course, this was a very important signal of activity of ICIs in this population. The most important trial, I think, is, a randomized study, the Empower Cervical 1, GOG 301, Angon 69. And this is a very large prospective randomized phase 3 trial in patients with cervical cancer previously treated with platinum-based chemotherapy, and they were randomized to receive cemiplimab or chemotherapy, standard of care chemotherapy. And as you can see, there was an improvement in overall survival for these patients with the use of cemiplimab. So that's, of course, very important. But if we look at these results overall, it looks like PD-1 inhibitors as monotherapy have really modest activity. So probably we have to go with combination therapy if we want to really have a strong impact on the outcome of these patients. So that's what we did with the Keynote 826 trial. This is a randomized, double-blind phase 3 study. And patients were patients with persistent, recurrent, or metastatic cervical cancer, not amenable to curative treatment, without any prior systemic chemotherapy, except for chemo, radiotherapy, good performance status. And the patients were randomized to receive the standard of care chemotherapy, so carboplatin or cisplatin and paclitaxel, with or without bevacizumab. And the randomization was for pembrolizumab or placebo added to the standard of care chemotherapy. And there was a dual primary endpoint, which was OS, overall survival, and progression-free survival. Here you see the results in terms of progression-free survival. We actually assessed the results in 3 different populations. You see the intention to treat population, the PD-L1 positive with a CPS score 1 or higher, and then the PD-L1 CPS score 10 and higher. And you see very consistent improvement in progression-free survival for all these populations. So the addition of pembrolizumab to standard of care chemotherapy with or without bevacizumab improve overall progression-free survival. But even more important is the improvement in overall survival, as you can see here. And this is true for all three populations, for the intention to treat population, for the PD-L1, CPS1 and higher, and PD-L1, CPS 10 and higher. So very, very consistent results. Now, it's important also to look at the protocol-specified final overall survival data, because the trial, actually, the analysis was positive at the first interim analysis, but then, of course, there was a longer follow-up, and we looked at longer overall survival. And here you see that this is confirmed with a very longer follow-up, a strong impact on overall survival. This is the PD-L1 CPS 1 higher population, which is the label population, because the drug was approved in this population. And here you see the protocol-specified final overall survival in all comer population. So still you see a huge improvement in overall survival. And we are talking about overall survival, and we are not talking about PFS. So this is incredible to see this improvement in OS with a hazard ratio of 0.63 and a p-value which is highly statistically significant. Now, if you look at the forest plot, these are the pre-specified subgroup analysis. I want to point out the subgroup of bevacizumab, yes or not, because as I said in this study, the use of bevacizumab was left to the investigator discretion. So was not randomized. If the patient was eligible for bevacizumab, she could be treated with bevacizumab. But you see that the benefit for the addition of pembrolizumab is seen in both the population with or without bevacizumab. So that's very important for me, because that means that when you have a patient who is not eligible for bevacizumab, because as you know, there are contraindications for the use of bevacizumab in this population. So you can use that, you cannot use bevacizumab. Still, by giving pembrolizumab, you can achieve a big improvement in overall survival. So that's a very, very important message, I think, particularly for this population. Now, even more important is that you can achieve an improvement in quality of life with this treatment. And this is peculiar, I think, of cervical cancer, because very often, for instance, in ovarian cancer, we look at, quality of life, and very rarely we can demonstrate an improvement in quality of life for any treatment, even the most effective treatment. But here, in cervical cancer, which is a disease with a lot of side effects and impact on quality of life, if you can improve the response rate and progression-free survival and the disease control, you can also improve quality of life. And I think this is extremely important to notice. So now, to go back to my original life, then you see what we achieve now. A huge improvement in overall survival with the addition of pembrolizumab to our standard of care. So this is a very long journey, but I'm really excited about what we could achieve with the addition of IO to our standard of care. And what I see even now in my personal experience and everyday practice, I see these patients not only responding very well to this treatment, but even with a very, very long-lasting response. So I have patients achieving a complete response, and this complete response is really lasting for many, many months and years, which is something previously completely unseen in this disease. We have also another study, the BEAT-CC, with a very similar study design, but the difference was that bevacizumab was mandatory in these trials, in the control arm and in the experimental arm. And the drug here is atezolizumab and not pembrolizumab. So also this trial was an academic trial, and demonstrated and confirmed the improvement in PFS for the addition of atezolizumab to the standard of care, including bevacizumab. And you see here that the advantage is really, continuing over time, and also in overall survival. So very important. So I think that's a very important confirmatory trial for the activity of IO in this disease. So what's next? Now we are reaching this point where you heard we can use IO in the locally advanced cervical cancer. We can use IO in the persistent metastatic or recurrent cervical cancer. And so what to do next? Because unfortunately, many of these patients will relapse. So we need other treatments. And we have a lot of therapeutic options, I think, that we are testing, of course. We tested, for instance, dual checkpoint inhibition, therapeutic vaccine, adoptive cell therapy, and particularly antibody drug conjugates. So just briefly, the combination of, for instance, anti-PD-1, anti-PD-L1 with CTLA-4 has a strong rationale. You see that the two drugs, they act at different level of the immunological cycle. So CTLA-4 is acting at the priming phase, and on the other hand, anti-PD-1 is acting at the effector phase. So we have several examples of this combination with some signal of activity, as you can see, nivolumab, plus ipilimumab or other combination. So that's very interesting. And in terms of therapeutic vaccines, actually, I must say the results so far are quite disappointing. We didn't see a very strong signal of activity, despite the fact that there is a strong rationale. So now the future is up to the ADCs. And so at this point, I would like to pass to Brett. And I'm asking him to talk about the ADCs in cervical cancer.
Yeah, that was amazing. Thank you so much. We've made a lot of progress, and it's really been inspiring as patients and families have sacrificed, but also as pharmaceutical sponsors have brought us, medications that actually work. So this is fun. ADCs are even more complicated. It takes, as I already mentioned, patients understanding what the benefits are, which one is right for me, what the risks are, and the providers. They have to have a knowledge in order to integrate this into their everyday practice. I think where we are in the life cycle, we have pretty good understanding of what ADCs are. And so I'm not going to review this, but this is sort of to set the stage. I also think we understand the mechanism of action, where the antibody drug conjugate technology enriches the cytotoxic payload with a very unique linker in the tumor microenvironment, which is then internalized, cleaved using the lysosomal pathway, and then ultimately having a bystander effect. We have several ADCs. I really don't have time to go through all of them. These are some of them really that are target driven. There are probably only one tissue factor, tisotumab vedotin. There are several HER2, trastuzumab deruxtecan is one, and there are several TROP2 antibody drug conjugates, and I just wanted to again introduce the topic. We have many ADCs in the clinic, 10 solid tumors. It's been a wonderful opportunity, and we have several of these in gynecologic cancer, really trying to optimize the patient experience hitting the target. And I want to talk about tissue factor first. And you're going to continue to hear about these. Again, I don't have time to talk about them. These are the FDA approved ones. I wanted to put them on one slide: tisotumab vedotin, tissue factor, mirvetuximab soravtansine, folate receptor alpha ovarian, and trastuzumab deruxtecan after the April 5th pan-tumor all-comer indication. So that includes all three of our cancers. So let's get into it. The most studied is tisotumab vedotin. There's a phase 3 trial here, ultimately presented in the New England Journal after it got accelerated approval, and then the phase 3. The same population as Empower that we did with cemiplimab versus physician's choice chemotherapy. And you can really see this wonderful benefit. It's not enough, but an improvement in overall survival and physician's choice chemotherapy and progression-free survival with a hazard ratio, as you can see, 0.70 for OS and 0.67 for PFS. So again, this is good. It's not good enough, but I think it shows that we can do antibody drug conjugate studies in cervical cancer. Again, it was a GOG collaboration with NGOT. Professor Vergote is the first author from Belgium. Well-balanced, excellently executed, and again, most patients were PD-L1 positive, and there were many patients who were immune therapy naive. But this is what you get. In this randomized phase 3 trial published in the New England Journal, and you see the waterfall plot on the bottom of these physician choice chemotherapy options, clearly tisotumab vedotin is better. It's better with an overall response rate, which you see here, and I already showed you progression-free survival and overall survival. And it's independent of the biomarker, which is kind of interesting. We all like biomarkers. We all like antibody drug conjugates, but the best antibody drug conjugate is one that works in a biomarker agnostic setting, because the biomarker was so strategically chosen that it's in all cancer cells. Now, the downside is toxicity. There's some very specific ocular toxicities, which you see here, and peripheral neuropathy and bleeding. Again, this is versus physician's choice chemotherapy. These were special adverse events of interest. And so we have a plan, particularly with the ocular opportunity. We have a plan. We can use drops that cause vasoconstriction that limit the delivery to the eye. We have cold packs, which can limit the delivery to the eye and the external nares, okay? And then we can use steroid drops for an anti-inflammatory response, and we can wash it out with lubricating drops. So we don't have time to get into this. You can download these slides. This is detailed, and there's a nice reference there, but we can sort of solve this in an efficient manner. I'm going to move on to HER2. HER2 is a wonderful target, not just in GYN. This is the history. I'm a history guy of approvals for HER2 targeted therapies. I don't exactly know the HER2 overexpression, amplification, and mutations in GYN cancers, but it's pretty high. Okay, it's pretty high. Probably endometrial cancer is the highest, ovarian is second, with cervical cancer the least. I draw your attention there to the lower left-hand corner, where the 2+ is 21% and the 3+ only 3%, but it's there. These were cohorts that have been studied specifically in several tumor types, including the 3 GYN, cervical, uterine, and ovarian. And this is a very novel antibody drug conjugate using the deruxtecan linker payload, the cleavable linker, okay? It has a high antibody drug conjugate ratio, the DAR of 8. It's very commonly used in breast cancer, and you can see what you get in cervical. So this is, again, IH3 plus 75% tumor shrinkage, IH2 plus 40% shrinkage, and now it's a tumor agnostic indication with a long PFS and a really, really, really exciting overall survival. Probably the vulnerability and safety is pneumonitis. So watch that. If you see these fluffy infiltrates, even though the patient is asymptomatic, it should be stopped. So It's now tumor agnostic approved at number 7. It's really exciting, and I put that in your deck. I'm going to finish with TROP2 because TROP2 is being studied in endometrial cancer, but also cervical cancer. TROP2 is one of those very common antigens. I said that TROP2 was the least, that HER2 is the least in cervical. Well, here, TROP2 is the most. And we just returned from ESMO, and these are the TROP2 antibodies that were reported. Very different. Sacituzumab tirumotecan is the same antibody as sacituzumab govitecan, but different payloads. And we're really excited about this therapeutic target in all gynecologic cancers. And this was a Chinese population, and I'm running out of time here, but the sacituzumab tirumotecan, which we call SAC-TMT. So let's not use the word SASI or SAC, because sacituzumab govitecan is different than sacituzumab tirumotecan. And this was a very important cervical cancer study, mostly done in Chinese patients. And some of these patients were even PD-L1 negative. But you can see that the response rate here was 58%. I think we've hit it. I think we've hit it. And this is a broader population than the HER2. I told you HER2 is uncommon. TROP2 expression is common. And we're really excited about this. And it sort of worked regardless of anti-PD-L1 or Bev experience. And we're rolling. These molecules probably have similar efficacy, these anti-TROP2 antibody drug conjugates, but they do not have similar side effects in sort of what we do in an inferential cross-trial comparison. And so what we have done, working with NGOT and the GOG, we're going to do phase 3. And we're going to do a phase 3 just like we did with Regeneron and cemiplimab, and just like we did with trastuzumab, tisotumab vedotin, same design, but this time the patients are IO exposed. It's a requirement. And so that's what we're going to do. This study is open. It's listed on clinicaltrials.gov, and it's enrolling really, really well. So I really appreciate it, and this is exciting. I'm going to sort of ask the same question to you, Professor Colombo. I think you're closer to getting 301 tisotumab vedotin approved in Europe than you are from pembrolizumab in the chemotherapy radiation setting. And by the way, I think mirvetuximab got a positive CHMP opinion last Friday. But where are we with TV in Europe?
Yeah, we are eagerly waiting for the TV approval. Unfortunately, we are not so lucky as you in the US that you can have access to this drug. Unfortunately, not yet, but hopefully we will get in soon. But I think everything is so exciting. I mean, your talk was so exciting about these new drugs coming, to the therapeutic arena. And it's really so interesting to see the activity that you can achieve with these incredible ADCs. So that was great. And thank you all for being on time also with your presentation. Maybe we have time for questions. I don't see questions from the audience, but
I can actually see them in the chat. I don't know.
Oh, sorry. Yeah. Can you? I'm sorry. I can't.
And I can run through them like 4 or 5 of them in less than a minute.
Yeah.
So does HPV positivity affect pembrolizumab? The short answer is no. Although HPV negative tumors are generally rare histologies, such as adenocarcinomas, so it's not really studied. But since the majority are HPV positive, it's really not necessary. Talked about biomarkers in ADCs, tisotumab vedotin, doesn't matter. Next question, do you use brachytherapy only in more advanced patients? Well, yeah, because if it's not advanced, I cut it out. But if it's unresectable, every patient needs brachytherapy. I talked about CALA. And here's a very, Dr. Aleshire, as a nurse in regional center, we don't see many trans patients and not sure how to appropriately ask about genital parts and need for screening. Can you address that?
Sure. So the current recommendations are to use an organ inventory. So rather than using a normal review of systems, let the patient know that you want to be sure they receive the appropriate screening for the body parts or organs that they have, and ask them to share with you, and as appropriate if you need to prompt or be certain. Also, being sure to use more gender neutral terms can be helpful. So for example, one might use the term chest as opposed to the term breast to refer to that area, and discuss if that type of screening were needed.
Nicoletta, I don't know if you can see the questions. Can you see them? There's a beautiful question here for you. Is so, should we continue to use bevacizumab now that we have 826?
Well, actually, I do believe bevacizumab is very effective in cervical cancer, probably even more effective than in ovarian cancer. So, yes, I do believe bevacizumab can play an important role in cervical cancer. So I'm not ready to abandon completely unless we can get a very, wonder drug which can cure all patients. But I don't know what you think. I do believe that also you are a big fan of bevacizumab.
Yeah, you're right. Some of my sarcastic friends call me bevacizumab monk rather than Brad Monk because of my passion for that.
Yeah. Yeah, I think, I see really patients responding so well. And of course, to have the possibility to combine pembrolizumab and bevacizumab is, for me right now, it's the best option that we can give to our patients in the frontline setting, at least. But the question is, now that we have A18, actually, okay, so would you, when do you want to see pembrolizumab used? You want to use it in the locally advanced, or you want to keep it for later? What do you think, Brad?
So that's a tough question. I think it sort of sounds easy because we all want to cure more patients, but when you use it in the recurrent setting, you showed there's a 12.1 month improvement overall survival. I don't know the answer to that. And I'm really happy that we're talking about sequential therapy, and that's the same in ovarian, right? PARP and Bev versus, PARP and then Bev. I don't know the answer to that. What do you think? What do you think?
Well, I do believe that actually the population which was included in A18 was a kind of advanced cervical cancer, because all of them had not only bulky tumors, but also positive nodes. So I think they were metastatic, cervical cancer. So at the end of the day, it is a population metastatic. So whenever you have a more advanced stage, probably you should use pembrolizumab. And as I said, the way I see it, I would like to use pembro upfront. I mean, in the locally,
Right.
and even, continuing. So even when you have a very advanced stage, cervical cancer, you can use a combination. And this does not exclude radiotherapy. If you can achieve a very good response on the metastatic sites, you can still then do radiotherapy. So that's my view right now. So I think we have to combine, the two situations. Yeah. So I think we are really run out of time. So that was a wonderful, I think, discussion, and it's so exciting to see these wonderful results in this kind of orphan disease. Now, we see so much improvement in the treatment of this disease. And so, of course, I would like to really try to sum up with some SMART goals, specific, measurable, attainable, and relevant, timely. So just to say, use inclusive language when discussing cervical cancer screening with patients. Dispel myth about the need for cervical cancer screening. in marginalized sexual orientations and gender identities, engage patients in shared decision-making about subsequent treatment options. So that's really very, very important. And of course, I would like really to thank Brad and Mollie for joining me today for a great discussion. And also thank you, our audience, for joining us today. Please visit the CEC Virtual Educational Hub for more useful oncology resources, including podcasts on gynecological cancer. Also very important, in order to receive credit for today's activity, please complete the post-test and evaluation online and click on the Request Credit tab. So good night, take care, and thank you for the amazing work that you do. Thank you all.
Thank you.